Welcome to Dysautonomia International's May 2018 webinar on managing sleep symptoms in POTS. Our guest speakers this evening are Dr. Mitch Miglis, an assistant professor of neurology in sleep medicine and autonomic disorders at Stanford, and Dr. Fiona Barwick, who's also part of the sleep medicine clinic at Stanford. We're really happy to have them here. And without further ado, they're going to jump right into the talk.
Great, thank you, Lauren. And thanks to Dysautonomia International for hosting this talk. So we're really excited to speak over the next hour on a problem that almost all patients with POTS have is issues with their sleep. So I will briefly go through some of the literature so far on sleep in POTS and some of how we approach a patient in the sleep clinic here. And then Dr. Fiona Barwick, one of our excellent sleep psychologists, who will go through some of the details in the treatments that we've used and have had some success in our patients. And then we'll try to leave plenty of time for questions because Lauren's told me that we have almost 500 people signed up for this. So I'm sure there's a lot of questions about sleep in general and especially sleep in POTS. So a brief background on sleep as it relates to postural tachycardia syndrome. Almost every patient with POTS has fatigue. So in the literature, this has been estimated in upwards of 90%. In fact, I think it's probably close to 100%. And in my experience, when I see a patient with POTS, their chief problem or symptom, the most disabling symptom, is usually not the tachycardia or even the orthostatic intolerance. It's usually issues with sleep or fatigue. Some patients also have sleepiness, so we try to make this distinction between fatigue and sleepiness, which are different. Fatigue, we usually define that as more of a sense of body tiredness or even muscle tiredness, whereas sleepiness is the actual desire to go to sleep or to take a nap. So almost every patient with POTS has fatigue, and some also have sleepiness, but not all. Many patients, in our experience, describe insomnia, and we kind of define insomnia as difficulty falling asleep, difficulty staying asleep, with daytime problems like sleepiness or fatigue. Many patients also have a delayed sleep phase, and we'll get into that in a minute. And there have been studies that have shown that this fatigue and sleepiness are very problematic for patients and directly correlated with reduced quality of life. So there have been several studies now that have looked at sleep in POTS. So what can we learn from the literature thus far? So we know that many patients have sleep-related symptoms. However, unfortunately, there have been no clear or consistent abnormalities on sleep studies in patients with POTS. And we use the term PSG or polysomnogram, which is just our medical term for sleep study. There's also one study that looked at NAP studies or multiple sleep latency studies, which is the test used in narcolepsy. And all these studies have not really shown a clear reason why patients are so fatigued or sleepy. They have shown that patients probably sleep more than they think they sleep, which is the case for all of us. However, the sleep is not refreshing. Again, they tend to be more night owls, tend to have a delayed sleep phase. And some, but not all, but some may be predisposed to mild sleep apnea, especially if they also have hypermobile Ehlers-Danlos syndrome, and we'll just touch on that. So this is what we subject patients to in the sleep lab. So you can imagine that not the easiest to sleep with. This is not a patient with POTS. I just found this on Google, but I think kind of the expression is what most patients feel when they have to go through this. The important thing is, the sleep study technology we use was developed maybe close to 100 years ago, and it doesn't really give a clear picture of the autonomic system during sleep. It's really designed more for measuring breathing, heart rate, and sleep staging. But in relation to POTS, it doesn't really tell us, what the sympathetic or parasympathetic systems are doing, and how sleep is affected directly by the autonomic system. We can use some variation in heart rate variability, but that's just more of an indirect measure. I mean, that being said, let's go through the data on what's been studied thus far. So the first group that really looked at sleep in POTS was the Vanderbilt group, and their first study used survey studies to just get a sense of how much sleep is bothering patients. And what they found is that, not surprisingly, patients with POTS score much higher on a sleep problems index score compared to controls. Then they measured sleepiness through the standard survey called an Epworth scale, and they found in their patients that their POTS patients were sleepier than controls. And they also assessed fatigue through a survey and found that fatigue is much higher than controls. So they did find that patients are, not surprising, they're sleepy, fatigued, and they have a lot of sleep problems. And then in a follow-up study, they used what we call actigraphy, which is a wristwatch that measures body movement. So we get a kind of sense, just like a Fitbit, on how much patients are sleeping and the timing of their sleep. And they also had the patients fill out sleep diaries to get a sense of how subjectively they felt they were sleeping. And what they found was something that we noticed in our patients as well, that they felt that they fell asleep on average of 56 minutes on their sleep diaries, but the wristwatches showed they were falling asleep in a more normal time period of around 37 minutes. So there may be some what we call sleep state misperception, which is a term developed in the insomnia literature for some reason, and this may get to the sense that just patients don't feel that sleep is refreshing. Patients had a lower sleep efficiency, and we define that as the time asleep, the time a patient spends asleep divided by the time in bed, basically what percentage of time they're sleeping in bed. We use a cutoff of 85% or above as normal, so POTS patients had a score of around 73%. Interesting thing is they also measured norepinephrine levels, and they found that the higher the norepinephrine level, more difficulty patients had falling and staying asleep. And they also found that this tended to correlate with heart rate. So the higher the heart rate on standing, the greater difficulty patients had with their sleep, and also the less REM sleep patients had. And we don't really know what REM sleep is for generally. There are lots of theories, but we do know that it's important in getting refreshing sleep, and decreased REM sleep is kind of a marker of sleep disruption. So then another group in Germany looked at the first study to look at formal sleep studies, or the polysomnograms on patients with POTS. And they had a group of 38 patients. And what they found was the sleep studies are generally normal. So patients had a normal sleep onset latency. We define that as the amount of time it takes to fall asleep, normal sleep efficiency, and also normal total sleep time. They also they looked at the heart rate and used what we call spectral analysis to look at various components of heart rate frequency. And there are some analogies you can draw with the frequency, and some of the lower frequencies are correlated with sympathetic activity, some of the higher frequencies with parasympathetic. They found some mild abnormalities in variability during transitioning between sleep stages, but not really enough to point the finger to any one kind of autonomic process going on. So, they suggested that there may be some altered heart rate variability during sleep, which could be indicative of increased sympathetic tone, but the data there wasn't really that robust. So the next group was a London-based group, so they also looked at sleep studies in patients with POTS. Similarly, they found that the sleep data was overall normal in these patients. They took a subset of patients that were very sleepy, and they did the nap studies on patients. So this is a standard test that we do in patients that we suspecting narcolepsy, and where we have them try to fall asleep a series of 5 times throughout the day and measure how quickly they fall asleep. And these patients with POTS did not fall asleep, so they scored in the normal range on the nap study. This group also looked at heart rate variability and did not find any consistent abnormalities there. They found that when they compared the patients that were sleepy in this POTS group to the patients that were not sleepy, they did find that the sleepier patients had mildly increased parasympathetic tone during sleep, and then postulated that maybe this is why they're sleepy. But really the mechanism here hasn't been well described, and really kind of at a loss in explaining why POTS patients have such severe sleep disruption. So we looked at a small group of our patients, and we found what the other groups found with the formal sleep study data, that overall it's pretty normal. With one exception, we did find that in our group of patients that a surprisingly high number had mild sleep apnea. Up to 68% had mild sleep apnea, and there may be some explanation for this. So when we went back and looked at the other diagnoses in our group, almost a third of our patients had hypermobile Ehlers-Danlos syndrome, and there have been some publications on this, that the connective tissue laxity in Ehlers-Danlos syndrome may predispose to upper airway collapse. So it may not be surprising that if you have EDS and POTS, sleep apnea may be partly why the sleep could be disrupted. So we also did sleep diaries, and we gave our patients a standardized circadian rhythm questionnaire, and we found that like the Vanderbilt cohort, patients slept worse than they think. They thought they slept worse than they actually did when we compared it to the sleep study data. And they also tend to score more as an evening subtype in their circadian rhythm questionnaires. Our patients were not very sleepy on the standard scores. They were very fatigued. And that's what I found in practice, is that patients are much more fatigued than they are sleepy. So these are a couple papers looking at sleep apnea and Ehlers-Danlos syndrome. It's probably fairly common. So if you have EDS and POTS, the next question is to ask is if you snore. And if you snore, that's a very good reason to do a sleep study to look for the very treatable sleep apnea. And the sleep apnea that we see in these patients, it's very mild. There's usually not desaturation, because most patients are young and thin, so they don't tend to drop their oxygen at night. But they do have what you see in that red arrow there. That's the nasal pressure, and that curve should be a nice smooth curve. And what you see is a flat top there that indicates some mild what we call flow limitation, which could fragment the sleep and wake patients up, but not necessarily lead to the full-blown apnea with pauses in breathing. So again, it really doesn't answer the question with all the studies that have been done so far. Why are patients still so fatigued? There are several theories, and these are all theories. None of this has been studied in POTS patients. Most of this comes from a long history of literature in insomnia. In some insomnia patients, they have shown that they do have these microarousals where they'll wake up seemingly spontaneously throughout the night and not able to get into good restful deep sleep. There is this concept of hyperarousal. Even in insomnia literature, we refer to it as tired but wired. So kind of a state of heightened fight or flight sympathetic tone. And this may be related to poor sleep in general, but there may also be some component of the sympathetic activation in POTS that kind of augments this. And so patients are in a constant fight or flight response, maybe in some level even when they're sleeping. There have been functional imaging studies where they've taken patients with insomnia and put them in a functional MRI scanner and measured blood flow during sleep. And they found that in all these regions in the brain, either in the cortex or in the brainstem, that there's increased blood flow or increased activity during sleep, which may indicate sort of inability of the brain to fully relax and reach that restful sleep. So this all comes back to a lot of the other theories in POTS that involve this heightened hypothalamic pituitary adrenal axis that associated with the subtype of hyperaginergic POTS that may lead to increased catecholamine secretion, this kind of fight or flight response, hyperarousal, not allowing patients to ever really shut down, so they can't reach that kind of state where their bodies are ready for sleep. So another overlooked fact is, and this is in a lot of other literature in sleep, is that arousals from any source, whether it's sleep apnea, restless leg syndrome, or even just spontaneous arousals and insomnia, every time there's an awakening during the night, there's a burst in sympathetic tone and sort of adrenaline, the heart rate, blood pressure go up. And if this happens frequently throughout the night, it actually spills over to the next day. So arousals from any source, if they happen frequently enough, can lead to increased sympathetic tone during the day, which is obviously not good for POTS. And this is another study I thought was interesting that, in a cohort of children and adolescents, POTS was 6 times more common in those who slept less than 8 hours per day. Whether this is cause or association is a big question, but it's definitely true. I think it's undeniable that patients who sleep less have a kind of heightened sympathetic state. So quickly on delayed sleep phase. So we found that a lot of patients with POTS tend to keep a more nocturnal schedule, so go to bed later, wake up later, and this is very difficult to break. And part of this may be due to the age of patients, so it's very natural to have a more delayed phase when you're in your teen years and your early 20s, and that tends to shift to more of a morning phase as we get older. Part of it may also be due to these the hyperaginergic symptoms that may keep patients up. Some patients can't fall asleep because their heart's racing or they're sweating. Some patients, if they have a lot of pain or chronic fatigue, that they may rest throughout the day. They may rest in bed during the day, which we try to break that habit. But the autonomic and the other medical problems may kind of limit patients from being mobile and out during the day, which then kind of reinforces this nocturnal predisposition. And we hear this all the time, that patients just feel their best late in the evening when everything's quiet. And this is not surprising, but this tends to make it harder to wake up and function during the day. Another thing is the beta blockers that we use all the time in treating POTS may also inhibit melatonin secretion, especially if we give them at night. So always something to think about if we're dosing propranolol or a beta blocker at night. It may be a good idea to give a little melatonin with that. And the melatonin itself may also blunt the sympathetic response. And in one study, 3 milligrams of melatonin in the morning actually decreased heart rate in POTS, although it didn't improve the orthostatic symptoms. So how do we approach an evaluation of a patient with POTS and sleep issues? Well, generally, the approach is very similar to how we would approach any patient with a sleep problem. We want to take a careful history, and a lot of this relates to the timing and the amount of the timing of sleep and the amount of time spent in bed. So we always ask, what time do you get into bed? What time do you turn the lights out to try to go to sleep? Which should be the same thing. It's often not. How long does it take you to fall asleep? How often are you awake during the night? Once you fall asleep and you wake up during the night, are you able to get back to sleep? And what time do you wake up? And what time do you get out of bed? Getting back to sleep apnea, anyone that snores, that's fatigued in our population here should probably have a sleep study to look for sleep apnea. But there can be other more subtle symptoms, such as frequent awakenings. We always think of sleep apnea. Dry mouth or morning headaches can be symptoms of sleep apnea. Other symptoms are restless legs. So POTS affects women. Restless legs is very common in women. Anyone that has insomnia, we should always be asking questions about restless legs. And restless legs is a symptom you have when you're awake. A lot of people have a misconception that it's leg movements. It's not leg movements. It's a feeling that your legs are restless, you can't get comfortable, and when you move your legs, it feels better, and it's almost always worse at night. So those are the key features of restless legs, and we can treat that with certain medications. Lastly, narcolepsy. Narcolepsy is rare, but it does tend to affect the same demographic, same age group as POTS. So if there's any, sudden falling asleep during the day, waking up with the muscles paralyzed, what we call sleep paralysis, or very vivid dreams, which can sometimes intrude into wake time, we always want to look for narcolepsy. And then lastly, the caveat is rarely autonomic symptoms can actually disrupt sleep, can wake patients up or keep them from falling asleep. So, these would include those hyperadrenergic symptoms, palpitations, sweating, etc. Pain, if you have EDS, pain is often a disruptor of sleep, or GI symptoms and headaches. So we won't go into too much detail here. At the end of the talk, we'll give a link to a paper that we've recently authored on this that has all of what we're going to go through in the webinar. But the main point here is that we don't always need to order a sleep study. The sleep study is really, in my mind, to look for sleep apnea or leg movements, or to really show that you sleep better than you think. So we don't need to order a sleep study for someone who doesn't sleep well to show that they don't sleep well. So sleep study is not always, the most useful. So in summary, based on the current literature, it is difficult to state that the sleep-related complaints of patients with POTS are the result of a single primary sleep disorder unique to POTS. A more plausible explanation is that patients experience disrupted sleep from a combination of factors such as, for instance, body fatigue, chronic pain, hyperactivity of arousal networks, and in some cases, this sleep state misperception. But I think it's important to remember that POTS is a syndrome that we don't completely understand, and there's probably multiple causes. So because of that, there's unlikely to be one single associated sleep disorder or algorithm that applies to all patients. However, with that being said, I'm going to turn it over to Fiona, who's going to go through some of the nuts and bolts of cognitive therapy that we've used to help a lot of our patients.
Thank you, Mitch, and thank you, Lauren and Dysautonomia International for inviting us. I'm glad that those of you who are listening are able to participate, and as Dr. Miglis said earlier, we'll definitely leave some time for questions. I will certainly be referencing some of the things that Dr. Miglis touched upon in this discussion of how to manage the sleep symptoms and fatigue that is so common in individuals with POTS. The approach we use is called cognitive behavioral sleep medicine. It focuses on the evaluation and treatment of various sleep disorders, most specifically insomnia, but certainly circadian rhythm disorders, hypersomnia, nightmares, by addressing behavioral, psychological, and physiological factors that interfere with sleep. Now, CBSM techniques have not been studied specifically in individuals with POTS, but there have been studies that have looked at individuals with chronic fatigue, individuals with chronic pain, including fibromyalgia, individuals with heightened sympathetic reactivity like trauma. And in all these populations, there has been a successful response to CBSM techniques. So even though there's no formal studies done, the likelihood is great that these techniques will help individuals with POTS improve their sleep. The typical targets for this cognitive behavioral sleep medicine are what we call circadian rhythmicity. We'll talk about all of these in a little bit more detail, but ideally we want people sleeping in the correct circadian window, supported by a very regular sleep-wake schedule. We want people to have a strong sleep drive. We'll talk about how best to do that. And we want people to have what we call low activation, which means calm mind, relaxed body. All of these things will help make sleep more likely. There's nothing we can guarantee sleep. We can't force sleep to happen. But if we've got the right circadian cues, a strong sleep drive, and low activation, then it is more likely sleep will unfold. The underlying principle for cognitive behavioral sleep medicine is the understanding that what we think is connected to what we do, is connected to how we feel, is connected to what happens in our body. And it's easy enough to think about situations where what we're doing can increase or shift our autonomic response. our activity level can affect it, for example. It's also easy to imagine situations where how we think about a situation can affect our autonomic response, can enhance our stress level or decrease our stress level depending on what we're doing. So this fundamental interconnection between thoughts, feelings, physiology, and behaviors is the premise for any cognitive behavioral sleep medicine technique, and indeed any cognitive behavioral technique in general. One of the first things we always do is help people understand what normal sleep looks like, because there are a lot of misconceptions about this. It's not anyone's fault. Sleep is not really taught anywhere. Even it's limited even in terms of how it's approached in medical school or psychology programs, so people have to seek out additional specialized training. What people read about or hear about in the media is often too blunt or not nuanced enough to get at the complexity of individual sleep. There's a lot more variability in sleep than people recognize. So we often start by showing people this picture of normal sleep. You understand this picture by knowing that along the bottom are the hours of sleep going from beginning of the night to end of the night. And then this, by the way, is probably a young sleeper. Most adults don't get or need 10 hours of sleep, although that is on the outside range of normal sleep. And then along the side here are one of three states we can be in. We can be awake, which is what you see here at the top. We can be in REM sleep, the rapid eye movement, or dream sleep, which is what you see here, these dark bars. Or we can be in non-REM sleep. And non-REM sleep has different stages going from lighter to deeper. We like to show people this picture because sometimes people don't understand that we are cycling in and out, as you can see here, of lighter and deeper stages all night. What's interesting is these deeper sleep tends to happen in the first third of the night. It does not continue across the whole night. We tend to get our deep sleep right up front, and in the second part of the night, we tend to get lighter stages of sleep. We also tend to do more dreaming, as you can see here in the second part of the night. And we also wake up during sleep. Waking up is actually a normal part of sleep. The average person wakes up 10 to 12 times a night. Now, usually the awakenings are very brief. Anything less than 3 minutes, people will not remember, or people are waking up and falling back asleep quickly. That would all be considered normal. But if someone is waking up and spending a prolonged period of time awake at night, that's certainly something that we can change with the CBSM. Finally, when we transition from sleep to wake, there is something called sleep inertia, which describes that state of feeling sort of heavy-headed, tired-eyed, a little groggy. That is a normal part of the transition from sleep to wake and will pass. The longer we spend in bed, the more prolonged that state can be. But it's not inevitable that we will wake up feeling bright-eyed and bushy-tailed. In fact, that's probably, once we hit adulthood, the exception rather than the rule because of the sleep inertia. So we want people to understand what normal sleep looks like. We also want people to understand that sleep changes as we get older. You can see a picture here. This is showing 5 to 85 years of age. Along the side here are just minutes of sleep. And then these different stages of sleep that we talked about, that light stage. Well, these different stages. Slow wave sleep is the deep sleep. The REM sleep, of course, dream sleep. This is wake after sleep onset, so essentially wakefulness at night, and then sleep latency, how long it takes us to fall asleep. I think the biggest difference or change is the reduction in slow wave sleep. As we get older, you can certainly see a dramatic change in that. Slow wave sleep is actually associated with the release of growth hormone, which is why when we were younger, we sleep more deeply. But we get less deep sleep as we get older. We can spend some more time awake at night, as you can see here, and maybe some more time in lighter stages of sleep. And we do get less total sleep overall as we get older. I think the take-home message here is because sleep changes as we get older, it's very important that we change with it. One of the most common mistakes I see people making is they're spending as much time in bed in their later decades as they did in their earlier decades. Inevitably, because they're producing less sleep, they spend some of that time awake, and then when they're awake, they tend to worry about sleep, which actually doesn't help sleep either. So sleep changes as we get older. It's important that we change with it. It's also important that we understand the individual variability in sleep. Sleep varies in terms of how much sleep people need and when they need to get it. This is a chart put out by the National Sleep Foundation that shows average time in bed across the lifespan from newborn all the way to 65 and older. The dark blue is the middle of the bell curve, like 54% of the population. The light blue on either side are the tail ends of the population, so 16% and 16%, all normal sleep. You can certainly see this trend that I described earlier, getting less sleep or needing less sleep from infancy through age 18. Once we hit age 18, the average stays about the same through 65 and older, 7 to 8, 7 to 9 hours. But the range can be pretty wide, 6 to 11 hours, 6 to 10 hours, depending on your age. So it's important to try to get a sense of what you think your individual sleep need is based on who you are and where you are in your lifespan, because both of those things are going to affect it. The other thing it's important to try to get a sense of is when your circadian phase is. As Dr. Miglis mentioned, a lot of folks who have POTS have a delayed sleep phase. Not exactly clear why that is, but we do know that there is normal genetic variability in circadian phase. So there are larks, there are hummingbirds, and there are owls. Larks tend to feel sleepy around 7 or 8 in the evening and wakeful around 3 or 4 in the morning. Hummingbirds sleepy around 10 or 11 in the evening, wakeful around 6 or 7 in the morning. And owls tend to feel sleepy sometime after midnight. The most common phase we see here is probably 2 in the morning till 10 in the morning. But I certainly have seen as late as 6 in the morning till 2 in the afternoon. And again, this is in part normal sleep, 50% genetic. Oftentimes we will see similar pattern in parents or children of night owls. So it's just, again, important to try to recognize for yourself not only what your natural sleep need is, but when you naturally need to get that sleep. We're not going to necessarily spend a lot of time talking about how to shift your phase earlier if you need to do that. Our usual advice to people is if you can sleep in your natural window, do it, because you'll usually get your best sleep in that biologically best window. Sometimes that's not possible, and if we have time, we can certainly discuss how you might want to consider shifting your sleep phase earlier. So we want people to have a very clear idea of what normal sleep looks like, including its variability. We then want to introduce some specific techniques for improving sleep based on the science of sleep-wake and these targets of CBSM that I mentioned earlier. So sleep drive is a big target in CBSM. Sleep drive is a basic biological drive, works like hunger. With hunger, of course, the longer you go without eating, the sleepier you get. Sleep can be, the hungrier you get. With sleep, it's similar. The longer you go without sleeping, the sleepier you get. And you can see a picture of that here. When we first wake up, our sleep drive is low because we've slept. But as we are awake and active during the day, it builds until at a certain point we fall asleep and then starts to come down. And then we just begin the whole cycle again the next day. So as I pointed out earlier, one of the targets of CBSM is to increase or optimize one's sleep drive so that when you do get to bed, it's easier to fall asleep and easier to stay asleep. Unfortunately, one of the things that reduces sleep drive is napping or dozing or resting. What can happen is if you're going through your day and you're building up your sleep drive, but then you take a nap during the day, it's like having a snack before a meal. You're not quite as hungry for sleep by the time bedtime arrives. So napping can disproportionately interfere with sleep drive. Our usual rule of thumb when it comes to napping, and again, there's individual variability with everything, so this is not necessarily the same for everyone, but our usual rule of thumb is if you're going to take a nap, it's best to keep it to 30 minutes or less, 7 to 9 hours before you get into bed. If you keep it to 30 minutes or less, it is less likely you will enter deep sleep, and deep sleep is what will interfere with sleep the coming night. And if you take your nap 7 to 9 hours before bedtime, you have plenty of time to build up sleep drive before bedtime arrives. The other thing that can interfere with sleep drive is spending too much time in bed, even when you're not sleeping. Spending time in bed actually reduces sleep drive because one of the ways sleep drive builds is by being awake and active. So one of the first things we often do with folks who are coming to us complaining of problems falling asleep or staying asleep is we often help them compress their time in bed. This is an example of what this technique looks like. This is someone who is getting into bed at 11 o'clock in the evening. They're not falling asleep right away, so that clearly there's some wakefulness here. They're waking up at 7, but not getting out of bed right away, not getting out of bed till 10, so they're basically in bed for 11 hours. There's some wakefulness, of course, in the middle of the night, and there's a little bit of poor quality fragmented sleep throughout the night. If I tell this person that they should get out of bed at 11, this is actually going to make their sleep worse. Why? Because the longer you spend in bed, especially when you're awake in bed. The less time you have outside of bed to build up sleep drive, so the lower your sleep drive. Also, when you're awake in bed for all this time, oftentimes when people are awake at night, they worry. If they're not worrying about sleep, they're worrying about other things, and worry is opposed to sleep. It is antithetical to sleep. And finally, what happens when people spend all this time awake in bed is they teach themselves, without even realizing it, to associate the bed with lying awake and not with sleep. For these three reasons, spending too much time in bed actually backfires, and it reduces the quality of your sleep. There's no way of improving your sleep by extending your time in bed. The only option available is to reduce your time in bed. If you reduce your time in bed somewhat, so here, we estimated this person was sleeping about 7 hours, so we gave them a 7-hour time in bed window. So now they're going to be out of bed for longer, which means their sleep drive is going to be higher by the time they do get to their midnight bedtime. So it's going to be a little easier for them to fall asleep, a little easier for them to stay asleep. That's the first thing. Their sleep will start to consolidate. Secondly, because they're spending less time in bed, they have less time awake at night, so there's less time to lie awake worrying. Thirdly, because now they're spending more time asleep when they're in bed, they're relearning the association between bed and sleep. And remember, we learn things just like any other animal. So just like a dog can learn to associate a meaningless piece of leather with something profoundly meaningful like a walk, we can learn the same thing. If every time we're in bed, we're sleepy or sleeping, our brain will start to associate the bed with sleep. And when we see the bed, it will automatically think of sleep. This is one of the most effective techniques at improving sleep for people, this compressing time in bed. Once someone's sleep quality improves, then we gradually start to expand their window very slowly, usually in 15 minutes at a time, until we hit that balance between good quality sleep and sufficient quantity sleep. But compressing your time in bed is the most effective way, apart from being more active during the day, of building your sleep drive and improving your sleep. The second thing you want to do, you want to establish regular circadian rhythms. So we have this master pacemaker in our brain, right behind our eyes, called the suprachiasmatic nucleus. Gets light cues that come in through the eye, get sent along specialized tracts to that pacemaker. And it's really the changing light cues, morning light or evening light, that help the pacemaker determine when it's time for us to be awake or time for us to be asleep. That information gets sent around this circuitous route to the pineal gland. And the pineal gland then either suppresses melatonin so we can be awake or releases melatonin so we can be asleep. There are probably one of the most effective ways to establish a regular circadian rhythm is to have a regular sleep-wake schedule. If you go to bed at the same time and get up at the same time in a window that is biologically appropriate for you, so if you're a night owl, we don't want you trying to be a lark and going to bed too early, but if you have a regular sleep schedule in a window that is appropriate to your circadian biology, your brain and body start to learn when you're going to sleep and when you're getting up, and they can help you with that process. When you're going to bed and getting up at different times, the brain and body never learn, and the process is always more effortful or more stressful. So establishing a regular sleep-wake schedule is a big part, in an appropriate circadian window, is a big part of establishing regular sleep-wake rhythms. However, sleep-wake may be our biggest circadian rhythm, but it's not our only one. Circadian rhythms actually govern most of our physiology and behavior. So they govern hormones like melatonin and cortisol. They govern physiology like body temperature and blood pressure. They govern performance, alertness, sleepiness, muscle tension, and ideally, and eating. Ideally, you want to have all your circadian rhythms aligned. So you want to support your sleep-wake circadian rhythms with a consistent sleep schedule and consistent bedtime routines, but you also want to make sure that your meals line up with that. So ideally, to keep your meals aligned, you would have something to eat within an hour of getting up, and you would finish your final meal within 3 to 4 hours of going to bed. You also want to make sure you have appropriately timed exercise and activities. You don't want to be exercising too close to bedtime because that tends to increase core body temperature, which keeps us awake. But you do want to get some activity during the day, of course, because that will help build your sleep drive. You also want to make sure that your light exposure is appropriately timed. You don't want to be getting too much light exposure, especially from screens close to bedtime, because that can suppress melatonin and leave you feeling less sleepy. So you want to time your light exposure strategically, and you want to also use substances, caffeine, alcohol, etc., appropriately as well. Now, this overlaps somewhat with sleep hygiene, which is something some of you may have heard of. Sleep hygiene are basically lifestyle or environmental factors that can help support good sleep if you have good sleep hygiene, that can disrupt good sleep if you have poor sleep hygiene. Sleep hygiene is not necessarily the most powerful technique in the CBSM or CBTI arsenal. The compressing time in bed and some of the relaxation training we'll talk about in a minute are more powerful, but I do suspect that for individuals with POTS, sleep hygiene might be especially important because of its emphasis on a regular sleep schedule, because of its emphasis on daytime activity, and possibly because of its emphasis on a protected sleep environment. You know, if individuals with POTS, as Dr. Miglis was suggesting, are subject to more microarousals, their sleep is more easily interrupted, it might be especially important that your sleep environment is as dark, quiet, and cool as possible with minimal interference. So sleep hygiene is part of the CBSM toolkit, but these other techniques, we've talked about the time in bed restriction, we're going to talk about relaxation training. These other techniques can be as important, if not more important. Dr. Miglis mentioned this sort of hyperarousal that might be one of the reasons why sleep is less refreshing for individuals with POTS. And so one of the systems we want to address, I mentioned that activation system. We want a calm mind, relaxed body as we're getting ready for bed or if we wake up at night. So we do need to reduce any of that fight or flight response, any of that sympathetic reactivity. This activation system, historically or evolutionarily, it probably was useful. This is a system that probably developed so that if we were in danger at night, it could wake us up, no matter how sleepy we were, no matter how dark it was, so that we could do what we needed to defend ourselves. So very useful in life-threatening situations. You know, unfortunately, there are lots of things that can set off this wakeful system. I mean, this system is not supposed to keep us asleep. It's supposed to wake us up. And there are things apart from life-threatening situations that can set it off. Things like worry, stress, etc. So you definitely want to make sure you give yourself ample time to offload stress before you get into bed, which is what this wind down period is all about. Most of us do not give ourselves enough time to wind down before we get into bed. We usually need at least an hour. And in this hour, you should not be doing any work-related activities, no stressful activities like bill paying, no real productive activities at all. You should be doing things that are relaxing and enjoyable. Now, relaxing and enjoyable in a specific way. Night owls, I often find, because their minds are so active and easily engaged at night, they can get very stimulated by surfing the internet or watching movies or doing other things. You don't necessarily want stimulating activities in this wind down period. In fact, if you're a night owl, you might even have to aim for a bit of boring with the activities because that's going to allow your mind to come down a bit. But winding down before bedtime, de-stressing before bedtime is very, very important because it's in a relaxed state that sleep is more likely to unfold. The other little thing that can set off that stress response is checking the time at night. It's such a strong habit for most people. A lot of people have a lot of difficulty letting this go, but the fact is that sleep gets disrupted when we check the time. We cannot make it into a neutral act. It increases, and they've done these studies even with normal sleepers. Normal sleepers who were asked to check the time at night before they got into bed, took them longer to fall asleep. If they checked it when they woke up at night, took them longer to fall back asleep. We can't stop ourselves from doing the math. The moment we look at that clock, we're already asking ourselves, oh, how long have I been asleep? Oh, how much time do I have left? Well, what do I have to do tomorrow? We're awake. The best thing you can do for your sleep schedule is set your alarm, determine what the best sleep-wake schedule is for you, set your alarm for your wake time, and then put the clock away, turn it away, or put it somewhere you can't reach it if it's too tempting to look. And ignore it. If you wake up at night, the only thing you need to ask yourself is, did the alarm go off? No? Okay. I can still continue sleeping. Now, reducing sympathetic reactivity is not exactly the same as enhancing parasympathetic activity. These are two different components of the autonomic system, and probably a lot of you are aware of this. So, winding down before bedtime, not checking the time at night, will certainly reduce that sympathetic response. Not necessarily going to enhance the parasympathetic response. We want both of these things to happen. So we want to reduce sympathetic reactivity, but we want to engage the parasympathetic system because that helps us feel more relaxed. So we want sympathetic response lower, the parasympathetic higher. How do you do that? The best way is through relaxation or self-regulation. You can see that a lot of the things listed here, the diaphragmatic breathing, the body scan, progressive muscle relaxation, guided imagery, even the ones on the right, which require equipment or an instructor or class of some kind, so the stretching or the biofeedback, the yoga, all of these things you'll notice have a focus on the body. And that can be very useful if someone is prone to worry or anxiety or rumination at night. Focusing on the body inevitably keeps us in the present because the body is always present, and that can help us relax. We usually, some of you may already be familiar with this, but we usually start with diaphragmatic breathing because it is a very convenient thing to do. You got to breathe anyway. It's always there. It's free. And when you breathe diaphragmatically, it's something that a lot of us, unless we are retrained, forget how to do. We're all born breathing from our diaphragm, but it's something, as we become stressed adults, our breathing tends to migrate upward and become more shallow, rapid breathing from our chest. If you retrain yourself to breathe from your diaphragm, diaphragmatic breathing can actually engender a relaxation response within a couple of minutes, because what it does is it triggers the vagus nerve. Once the vagus nerve is stimulated, that actually sends a signal to the brain. And the brain's response is to say, hey, relax. That is actually an activation of the parasympathetic system. So when you're really breathing from your diaphragm, you can engage your parasympathetic system. And it's certainly easy enough to do if you're getting ready for bed or if you happen to be awake at night. As you saw from the previous slide, there are lots of other options out there. Given the degree of autonomic dysregulation that Dr. Miglis has pointed out, I would believe that these sorts of self-regulation strategies would be a crucial part of sleep management toolkit for anyone with POTS. Now, finally, Dr. Miglis referred to this difference between fatigue and sleepiness. So sleepiness is literally the propensity to sleep. Your breathing slows, your eyes get heavy, your head starts to nod. That's how you know when you're feeling sleepy. The usual cause of sleepiness is lack of sleep, sometimes sedating medications, but generally lack of sleep. Fatigue is different. Fatigue is when you feel physically and mentally wiped out, exhausted, depleted, but not necessarily sleepy. There are lots and lots of different things that can cause fatigue. Boredom, negative moods, spending too much time in bed, being too inactive or overactive, poor physical conditioning, excess weight, stress, depression, anxiety. I mean, the list is long, as you can see. Why is this important? For two reasons. First, you want to be sure that you are clearly distinguishing between feeling fatigued and feeling sleepy, because you don't want your default response when you feel tired to be, oh, I should go to bed. Because if you end up spending too much time in bed, you can actually worsen your sleep based on what we talked about with sleep drive. So you want to make sure you're identifying sleepiness versus fatigue properly. And the second thing is, if you are actually fatigued and not sleepy, you want to identify what's causing the fatigue and figure out how to manage it appropriately. So I think one of the differences for individuals with POTS, as it is for individuals with chronic fatigue or individuals with fibromyalgia, in addition to the CBSM techniques that focus on managing sleep and wake, I think you also have to manage on focusing fatigue. It's a separate category than the sleep and wake. These remaining slides are basically resources for you all. This is instructions for how to find in-person CBTI provider. There's a website, the Society of Behavioral Sleep Medicine, that has a provider search that pulls up, when you click on the United States, a map of the US, and you can click on the state and find in-person providers who are certified to competently provide this therapy. There are also some nice online versions of CBTI now. So Shut-Eye, Sleepio, CBT for Insomnia, all of these are straightforward presentations of CBTI principles. And there's certainly things you'll be able to get from them that will help you improve your sleep. It's not going to address everything, because as we were just talking about, there are additional factors that you have to take into account, like the fatigue. But it can certainly give you a very good exposure to and experience with the cognitive behavioral therapy for sleep problems. There are lots of apps, lots of resources online and apps for enhancing relaxation, practicing self-regulation. CBTI Coach, Mindfulness Coach, ACT Coach, these are all free. They have a few sort of tried and true relaxation exercises. So generally the diaphragmatic breathing, progressive muscle relaxation, maybe a positive visualization. Apps like Headspace, Sattva, Calm, 10% Happier, Breathe, Inscape. These are all programs that are designed to help people develop a daily meditation practice. So you pay a monthly or yearly fee for access to the full services. Insight Timer is nice because it's a free app and there are a lot of different guided meditations. And I have found that when people are just getting into meditation, people can have very different responses to voices and pacing and music, and so it's nice to be able to experiment a bit. So lots of meditation apps. There are websites that offer similar guided meditations or full courses on mindfulness-based stress reduction, all of which would be useful. All right, I think that finishes my portion, so now we can probably open it up for questions.
So thank you so much for those excellent presentations. I think everyone's going to get a lot of helpful info out of this, and it's a hard topic to cover because everyone who has a sleep problem might have a sort of their own nuanced version of it. So everyone is invited to ask questions on the GoToWebinar toolbar that should be on the left side of your screen if you're listening to our live broadcast. Please do not ask personal medical questions. The doctors can't answer your medical questions and have detailed questions here, but general questions about sleep issues in POTS and general treatment question ideas are fine. So there's already a couple questions on there. So here's one that I think probably a lot of people can relate to. I could ask this question myself, but this is actually someone else's question. So she says, I just don't get sleepy at night. I could stay up most of the night, and she wants to know how can she begin to change that? It doesn't really fit within her lifestyle.
Well, the first thing I would, it's always hard to answer these questions because you need a lot more detail, but the first thing I would want to look at is degree of activity during the day, what's being done right before bedtime, activities right before bedtime, sort of typical sleep schedule if there is one, activities during the day, level of activity during the day, degree to which relaxation strategies of any kind have been incorporated. So those are just some of the things I would want to know.
Okay.
And just to add to that, I think to emphasize the identification of your own circadian rhythm, your own predisposition. Are you more of a night owl? And if so, maybe there are things that you're doing that are reinforcing that, especially the screen time at night. And that's where we can use light timing and low dose melatonin to try and do the best we can to shift, the natural circadian rhythm. And in terms of POTS autonomic symptoms, we always want to ask just to make sure that there's no, more typical POTS symptoms that are disrupting sleep or playing a role in the sleep timing.
Okay. Our next question is, someone wants to know, is there any connection or have you seen other cases of POTS patients with sleep paralysis? I'm not even sure what that is, but I'm hoping that you guys know.
Yeah, so sleep paralysis is actually not that unusual. I think it happens in 2 to 3% of the population. Sleep paralysis is more likely to happen if you're more sleepy, if your sleep is worse. The sleepier we are, the more likely we tend to get stuck in these states like sleep paralysis where we're kind of in between dreaming and waking, which is what sleep paralysis is. It's the paralysis of your muscles that normally happens during dream sleep that persist after the person wakes up and their muscles are still paralyzed. It's typically thought of in sleep diseases as a symptom of narcolepsy, and the other, what we call central nervous system hypersomnias, which interestingly may overlap with POTS. And this is another project that we're working on because a lot of patients with these hypersomnias also have autonomic symptoms. So if I would say if a patient not only has sleep paralysis, but they're also excessively sleepy and have those symptoms of narcolepsy we touched on, then it would be a good idea to see a sleep doctor. If it's infrequent sleep paralysis, it's probably not directly related to POTS.
Okay, just a note, because I know we're not trying to give personal medical advice, but this individual who asked the question said narcolepsy has been ruled out. So maybe she could talk to her doctor about the other thing that you mentioned. What was it? Central nervous system?
The hypersomnias, or that disorder, the one that I'm referring to is idiopathic hypersomnia, which is usually diagnosed the same way narcolepsy is. So if all the testing for narcolepsy has been done, that's been looked at as well. So it may just be a function of just not sleeping well and being more exhausted in general.
Yeah. Here's a good question. So this person is asking, says many POTS patients who have the more hyperadrenergic phenotype report vivid dreams and nightmares causing arousal while sleeping. Is there a way to combat this without higher and higher doses of medication? Like I know some doctors use sort of beta blockers to chill out their hyperadrenergic POTS patients. Other doctors have used alpha-2 blockers, I think. Do you see this in your more hyperadrenergic POTS patients? And if so, do you have any strategies to address it?
I can briefly touch on the medications, and then I'll let Fiona can give her opinion on it. So in terms of medications, there may be a connection with increased sympathetic tone and basically like a PTSD state. And I found that in those patients, the best treatment has been a kind of low dose of an alpha blocker like clonidine at bedtime, which really helps to dampen the sympathetic response. But the non-medication treatments are really what Fiona went through with all of the, I think, paced breathing and these sorts of things. So
and there's some additional, so there are some empirically supported treatments for nightmares in PTSD. They're called imagery rescripting therapy or exposure relaxation and rescripting therapy, and they're based on this idea that daytime imagery is often incorporated into our dreams, including our nightmares, that having nightmares, especially if it's over a long period of time, becomes almost a habit. The brain automatically defaults to the nightmares because that's what it knows. And so you have to teach the brain a different habit and give it a larger repertoire of positive imagery during the day for it to draw when it builds or creates the dream. That's the basic idea behind imagery. So what they have you do is practice positive visualization, but ultimately take a recurrent bad dream or a theme for bad dreams and rescript it, and then practice that rescripting. It sounds like a fairly simple and almost too straightforward approach. Nonetheless, there was a recent meta-analytic review that showed good support for reducing the frequency and severity of nightmares using these techniques.
So we have a question actually from somebody who says, I know this webinar is about POTS, but can you briefly discuss sleep problems in more like autonomic failure conditions, like people who have neurogenic orthostatic hypotension? Are there differences in what you see in the POTS patients and the sleep in those patients?
I think there's a big difference. Like we went through, the underlying primary sleep disorder, at least in our experience in POTS, is trouble sleeping, is the insomnia, which patients with pure autonomic failure can have. But pure autonomic failure is a form of an alpha-synucleinopathy. It's a neurodegenerative condition, and the big, there's a lot of associated sleep disorders that go along with that, but the big one that we tend to focus on, maybe dream enactment. So patients with autonomic failure may probably do have greater incidence of REM behavior disorder, where they act out the dreams, and that can be potentially dangerous. Sleep apnea is probably more common in these conditions as well, much more than in POTS. And restless leg syndrome is much more common. So patients can have insomnia, but that tends to take a backseat to the dream enactment, the breathing, and the restless legs.
Okay, so we're sort of at the end of the webinar here. If I can just ask you one more question, because it's sort of an interesting one in general. This person wants to know, is it normal to consciously be able to control your dreams when you're sleeping? Unconsciously, consciously, I guess.
So the phenomenon that this participant is describing is lucid dreaming. Lucid dreaming is the ability to recognize that you're dreaming and actually exert a certain amount of control over it. It is an aptitude that appears to have some individual variability. So there's some people who actually seem to be more able to do that than others. And although there have been efforts to try to teach or learn lucid dreaming or enhance one's ability to lucid dream, they have not met with any success. So it seems to be more of an individual trait ability.
Interesting. All right. Well, thank you so much for your time and your expertise. And for everyone who is still listening, we will be sharing this video. We'll email it to everyone who registered for the webinar, whether they were able to log on or not tonight. And we will post it on our Autonomic Disorders video library on Vimeo. And we will also share it on our social media accounts in a few days. So thank you very much. And we'll see you next month.
Thanks, Lauren.
Thank you, Lauren.
Take care. Thank you.
Bye.
Bye.